Good evening, everybody out there. I saw those numbers increasing rapidly to 100. It's probably more than 100 now. Welcome to this evening's lecture on risk management in healthcare. This is such a critical issue in health because we are faced with risks all the time. In fact, if we go to your own home environment, you know, there are so many risks there that the one big risk is the petrol that is always increasing, and the salary is not going up, and you're having to keep yourself within budget or to still meet whatever needs there are in the family. So it's not easy. So let's get to the hospital side. You know, I've got some. Well, now I've got to move this, and it's not moving. Oh, yeah, you ask share screening.
You are sharing, try to click with the mouse on the slide, then use your arrows, yeah? Just click once, yeah? Yes.
There we go. Right, so I've got a few objectives that I set. Well, there's the introduction, context, the purpose for risk management, the process, designing now he's going faster than expected. It's got to go back. Process, designing a strategy for the types of risks and general risk, healthcare-related risk, role players and underlying dynamics in health establishments and in prevention. And then I've also got some clinical pictures showing risks taken, and these pictures were taken by the Office of Health Standards Compliance. And it's really good to just show a few of them to show how easily, you know, we can find ourselves in trouble with risks that we didn't identify. So any health establishment is a high risk area for both the patient and the employee. Example, I'm taking you to COVID-19. I mean, this was one big problem for all of us. And whether you were in the hospitals or outside of the hospitals, everybody was just fearing that, you know, your family member, that's in hospital, or your family member, the mother or the father working in the hospital may get COVID. And that was really something, the last 2 years was really problematic for all of us, you know, and sometimes you think back and you wonder, how did we get through it? But just think about all the risks that was linked to that, you know, and then there's others, you know, other problems like TB also. TB is equally high. Latest results is exceeding COVID now, you know, and people have neglected this. So it is still a risk for us as employees also to basically contract the problem. Then the clinical risk, example, patients may fall out of bed, develop pressure sores, develop hospital-acquired infections, post-op complications. There are physical risks, your environment that you are functioning in. You know, a patient walks and somebody's cleaning the floors and there's no board that says mind, you know, wet floors, and the patient slips. You know, it so easily happens. And these patients go home and while they're in hospital, you know, they kind of share with you that it's not a problem. And I've had that experience where a patient said that it's not a problem, it's okay. So, you know, we did the x-rays and we found that there was a fracture. But when that patient went home and she got home and found that she could not use both hands, the one arm was in plaster and she couldn't function. She then went to her lawyer. So there's physical risks. That's just one example. There are many, many physical risks. There's the theaters with a number of risks that occur there, and the use of highly inflammable gases, solutions. You know, this is just to open up our lecture for this evening, what we are basically facing on a daily basis. And not only what's happening that you can see within the hospital, but there's other aspects. And the question to you is that how many of you have now listened to what is the Rand dollar doing today? You know, How many of you have listened to what the petrol is doing on the international markets? Because these factors all influence your environment and the health care that you're going to deliver to your patients, because we still have to keep within budget. Although that petrol is going higher every month, I wonder if they're going to drop it a little, because it was less than 100. And let's see what they're going to do about it. But it influences us because we're not going to get extra money. And whatever increases, if the rand dollar, which is now again moving up, if that, our purchases from overseas, we just have to pay. I've recently been on holiday, and of all places, I went to the UK, and I must say this holiday was planned before COVID, and I almost lost it. And it was paid for that time. So finally, I could use it. They allowed us to use the credits. But just purchasing a pound costs more than 20 rand, 1 pound. And now you're out there, you want to buy yourself a hamburger, and it costs you about 5 pounds. Just think what's 5 pounds, 5 times 20, quite a bit. I had to cover a small case, and the lady said to me, it's 15 pounds. Am I okay with that? Because at that moment, the rand dollar was 20 rand. The pound and the rand was 20 rand. So it influences us. And as leaders, we have to take cognizance of what's going on around us all the time, because it's influencing us. Let me go to my next slide. The context within which we function. Now, most of us, in fact, all of us are probably, in the clinical environment. So we are focusing on the constitutional requirements all the time. Even if you are teaching, you are vigilant about the legislation that's around, that's dominating whatever you are doing. Teaching in the clinical environment, and I mentioned now the Constitution, there's the Health Act, there are many acts, the corporate governance, right? Everything, those principles of corporate governance that we have to adhere to is critically important. If you basically in the private sector, they don't have the PFMA, but they have other ways that they have to keep within their budgets and the rules of finances, auditing that has to be done. Within the public sector, the PFMA, and I'm sure many of you have now heard, that some of our leaders have basically not kept within the PFMA, and those principles. That act is so critical. The healthcare organization, in accordance with the type of business ownership, the professional, ethical, and legal framework of all healthcare practitioners, we are functioning within that environment all the time. We are always constantly aware of the ethics that's governing our practice, the legal requirements. So we can actually put yourself into a little cage, a block, and then you put just all the things around you that dominates your practice. And then there are various risk-related legislation. Now, the purpose for risk management. Why is it that we should have risk management? Why must we identify risks even in our home environment, at home? What's going on there? What are the risks? Not locking your doors at night and leaving the windows open. What are the risks that's linked to that? And you plan. You plan as a person at home, the owner of a house where you are functioning, that you must make sure that the doors are locked, because it's all about security. Tomorrow, somebody may break in. You may not have been at home. They break in, and the insurance says to you, but you didn't meet all the requirements, as you should have, because you're supposed to have had burglar guards, and they have a long list of things that they tell you with a reference to that. So the purpose for risk management is that we need to prevent risk. So let's see what the Institute of Risk Management, IRM, how they define what is a risk. And I quote, it's the combination of the probability of an event and its consequences. So we are at all times within the clinical environment, we are aware of risk. We identify risks. Just think you know, it's a small hospital, but a national road is close by. But you're just a small hospital, you know, a district hospital, maybe even smaller. And but you're based very near to a national road. What are your risks? Just because of your position, what are the risks that's linked to that? There could be major accident on that road. Where are they going to go to? They're not going to run to the near Johannesburg, to the nearest big city, or to that hospital. They'll come to the closest health institution, and you have to manage it. So the question is, do you have a plan in place? Do you have a disaster plan in place that have identified the risks just around that health institution? Furthermore, why do we have the purpose of having a risk to plan for your risk management is that the protection of the organization, the staff, the assets, and the profits against consequences of risk. That's the first question that the media will ask. Did you have plans for this? Why did this happen? Why did the hospital burn down? And then they start scratching and they look for reasons. Why did this happen? That's what they do. And they're going to be very quick to point fingers to say that they didn't even have a plan, you know, a disaster plan in place. They didn't have a plan for internal disasters. They didn't identify that something like this could happen in their hospital. I remember we were teaching a group of students, and one of the managers said to us that she would like to share with us what happened to them when I was teaching disaster management. And she said they were caught napping, completely off guard. They had no plan. And their 24-hour, basically a clinic, a comprehensive clinic, basically went up in flames. It was burning, and they had patients in there. A second in charge person didn't know where the hospital was. She was phoned to say, look, you've got to come to the hospital, to the clinic. It's burning. She drove miles out of the city, you know, and she was in such a state of shock. They couldn't believe what was happening to them. So what would the media say in such a situation is that we never had a plan to protect the patients and the hospital and all its equipment, their assets. So that's one reason, the purpose for risk management. It's purposeful, it's proactive initiative. We prevent and we mitigate of any possible risks. We have to identify that. Furthermore, patients' right to a quality, safe environment is very important. If you don't identify risk in your environment, and patients are subjected to that, take infection control. That's a big risk. If you don't have a policy in place, SOPs, and all your staff are not aware of how to prevent cross-infection in the hospital and that patients develop infections, you're in big trouble, because that's also a risk. Create a culture of risk awareness and safety among staff. That's critical, that everybody's aware, even your most junior nurse, most junior intern, no matter who it is, they must all be aware of it. And this applies to everybody that works in the hospital or in a health establishment, because they are all of them play a part in providing safe, quality patient care. All of them, whether the sweeper cleaning the floors, washing the floors, or the gentleman sitting out there in the stores having to give things to you when you order, you provides or brings the linen to you. Whatever task somebody has in the hospital, take it as a circle. Everybody's a dot on that circle, and we all connect. And if there's one dot not there, then there's a break in that circle. It's not a complete circle. So we must all the staff, everybody in your health establishment must be aware of the risks. And they too should identify risks that they see, well, there's something here. I may have to discuss this with the manager or the CEO, because potentially we're going to have problems. Rather be wrong about something than having to have been right and you didn't take action, you didn't plan, and something happens. It's part of our daily activities. It's linked to quality care, as discussed. And what's very important is that we develop a risk register. A risk register should always be dynamic. It's not something that you design and you put it somewhere on a shelf and you save it. And every now and then people can look at there, what is the risk? Risks are happening all the time. And some of them are also being resolved, you know, so, and there's plans in place. So a risk register should be developed. You must identify the risks that the hospital faces and put plans in place with reference. In your register, you have various columns, and you can also rate the risks. You know, that's something for another lecture, but you rate the risk. You know, is it an extreme risk, or is it really going to threaten patient care? But you are going, that is important, and that you always look, monitor, and see if you are resolving problems, risks, or are there more risks to be added? And that's what the risk register is about. It's a dynamic document, something that it's not something that's static, that you just put away somewhere and you open it up one day. Then your leadership, you know, our leadership must function, you know, and these are the principles of corporate governance, according King 2, King 3. That's where, you know, when the new South Africa started in 1994, you know, these guys were very smart. They started off with the King 2 and King 3. They started developing plans, how South Africa should function, how we should have good corporate governance in all our places, not only in the state, it's all over, so that we prevent problems such as fraud, and the famous thing that you always hear every day is corruption. And it's such a word that I think that's the word used the most on television. If one should really go and take a tally of that, you'll find that it's really used quite a lot. And it's actually very sad. And it's not only in South Africa that it's a word that's used a lot. It's an international problem where there's always fraud, but there should be good governing principles. And your leaders, your leadership, you know, if your leadership is good and provides good leadership, ethically correct, you will find your juniors will follow and do the same. But if it's the other way around, you will also have problems. So even there, you identify risks in leadership if there's problems, because there's finances that must be controlled, regular auditing that must be done, quality improvements, that plans that must be done. There's policies that must be developed, and SOPs and be implemented. And leaders normally have that vision to see. They're the guys that don't look at the mountain in the front. They look at what's going on behind the mountain, so that they are prepared for any problem that may arise. So leadership, good topic that we should also explore about good leadership skills and management skills. Then, of course, as we mentioned, the legal and ethical framework. That's important that we understand. And it's, you know, it's sad actually when we find that things are not, our practitioners are not functioning within that legal and ethical framework. It's very sad. I just said to Dr. Lesego earlier that I'm busy teaching in the Eastern Cape, and Dr. Madonda shared with us that the budget, basically, of the health budget is basically exceeded by litigation. How did it happen? Why do we have such high risks? And it's not only this, it's throughout the country. I've identified that through our research that litigation is a problem in our country. And it's basically problems that have risen right at the bedside. And then most of the problems is at the bedside. So if we can just keep within our legal and ethical framework, then we shouldn't have problems and function as we should. So the process of risk management, let's talk about this process. We could it's divided into the following dimensions. There's the corporate governance. So you'll have lots of risks that's linked to corporate governance. The business continuity management, disaster management, we've touched on that, occupational health and safety, and adverse event management. I just want to touch on this business continuity management, and I listened to Dr. Lesego that says I serve at COSASA. So COSASA is a non-profit organization, and I serve on that board. And when I was recruited to serve on this board, one of the first things that I learned is that they have to see that their budget is, that they have enough money to be viable, that the business can continue. Otherwise, they're in trouble. And then the board will have to give answer. And that scared me. It really scared me because, wow, we'll have to give answer if there's not enough money, that type of thing. So one must be sure, and this is private and public, do we have enough money to continue with caring for our patients as what we should? Or, as I've just mentioned, is that we now have so much litigation in our country that we're heading to a disastrous situation if we don't turn that around. And that's for sure. If we don't have more move to mediations and continue going to court for all the litigations, that's about 120 billion rand this year, then we're in trouble, because every case that pays out is about 40 million. And mediation will cut down that cost. So that's something to keep in mind as leaders, that we need to have money to continue managing our patients and providing safe, quality patient care. I mentioned disaster management. I gave you an example of that. Occupational health and safety. There's lots of problems in hospitals that's linked to this, that we have to make sure that our staff is within an environment that's safe. And I'm just thinking now of the little book that we have, that you have to jot down everybody that was exposed to a patient with TB. You have to, because they could easily, tomorrow a nurse gets TB, they're going to go to that book. Where were you? Did you get it outside, or did you get it in the hospital? So occupational health and safety is critical, not only with reference to diseases, conditions, but also the environment as such. Are we working in environments that are safe and conducive for safe, quality patient care? And then adverse event management. Your adverse event management, we don't need an adverse. We don't need any adverse events. We must prevent these events. But as it is, there will always be mistakes, but not as what's happening today in our country. So how do we identify then the risks linked to these dimensions? Is that you have to identify a risk. And as I mentioned earlier, is that discuss the risk with your leaders and explain, that, look here, this is a potential risk. Something's going to happen if we don't put something in place. We definitely have to do. So you identify, you assess the risks, prioritize risks of different kinds based on the principles of strategy analysis, strategy development, strategy execution, and strategy review. Whatever you put in place, once you've identified a risk, you've planned, you've put something together, and you've implemented it, it doesn't mean it's cast now in stone. You need to revisit that and always review if that the risk as you have planned to prevent it, if it's still the way it should be. So that's important that you always review that, a risk plan. So designing a strategy should consider the type of risk. What are the threats and hazards which may cause harm? Financial, our biggest problem today. And I mentioned earlier on how volatile the rand dollar is. It scares us. And somehow the dollar is used just all over the world. You know, I think it's just Americans benefiting from that. But we have to purchase everything that we want from overseas. We have to purchase in dollars. And it's really causing problems for our country. So it can have a positive, if it's a good situation, could have a positive effect on your environment. But I'm not sure when are we going to get to that positiveness, because these days it just seemed to be negative. Every day I sit and I listen to what the rand dollar is doing, what the pound is doing, what is the euro doing, because that is how we determine how it's going to affect us in the clinical environment. Are we going to manage? Will we be able to manage patient care? Because that don't change. If you have to manage a patient, there's specific medications to be given, specific surgical interventions. It still has to take place. But you can't take a shortcut because now suddenly you don't have money. And there are lots of, things happening in our country where even young nurses are standing up and saying that they are not going to be accomplices to patients dying. Because that is actually what happens, because patient dies. If we don't have the treatments to give them and the care that's supposed to be provided, we don't have enough nurses, enough doctors, enough physiotherapists, and we just make do, we will end up in trouble. Then internally, fires, accidents, injuries on duty. These things are happening all the time. Then there's the external problems, the natural disasters, floods, fires. And I always say, ask the question, where am I based? Where is this hospital situated? Is it a hospital near the airport? Is it a hospital that's close to highways? Because whether you're a small or a big hospital, if there's an accident on that road, they're going to come to you. And there's floods. These things happen suddenly, these external things. It just happens. If you've now watched the news, what's happening in Pakistan, it's a disastrous situation. They've had some words, the way they described it today on one of the television news. I was listening to one of the news items, and they really described it as really disastrous. And this is because of climate change. Now, that is one of the risks. Climate change is a big risk to any country. Do we have plans in place? Are we doing what we're supposed to be doing? They've even said today that all of these in Switzerland, all of the ice, those, the mountains are covered with ice, but it's slowly melting. It's melting. So soon you'll just be able to see, in fact, some of the parts of the mountains are visible already. So these are things that's happening, and it's happening very fast. But do we have plans in place for climate change? Furthermore, the ISO classification of general risk, that's the internal organization for standardization. Let me mention a few of the way they put out the risks, and they describe it as their classification includes the following: economic, health. Now, just listen to this. This is the stuff that affects us. Economic. The economical climate all the time is a factor. Health, is a factor. Occupational health, safety and environment, information technology and information security. If you thought your phone is up to date, you've got the latest. The bad news is by tomorrow, it's not up to date. It's old. Technology is rapidly changing and there's new things happening all the time, you know, and making things much easier for us. Now, who thought we would give lectures as what we are doing tonight? That we would have everybody linking up throughout the country and we link up to a lecture. This was one good thing about COVID, that we have this. And so it's happening. And we, as in the health environment, needs to also keep up to date with technology, because that's also changing with the care that's being given to patients. What are they doing? What's the latest? And I was told this is now going to mostly nurses. So for the nursing profession, you need to always work with your colleagues of the multidisciplinary team, so that we know who is doing what, who's inventing what type of plan must we have in place. Let's think about the heart transplant that was done. And I'd like to ask the nurses if they were ready for that heart transplant when it was done, that very first heart transplant on Washkansky. Were we ready for that? Did we have a nursing care plan in place when we knew this was happening now? So never before that we have technology moving so rapidly as what it's doing today. And there's the insurances. Just to touch on the insurance of the state. Do we have an insurance in the state? No, we don't have insurances. So if we have problems with adverse events that leads to litigation, basically what's going to happen is that the health departments will rob Peter to pay Paul. They will use money of the budget, the health budget, meant for something else, for patient care, and to be able to meet that requirement. And this is what's happening in many provinces, is that instead of us making sure that our maintenance are there like it should be, you know, the well-maintained hospitals, well-maintained grounds, and so on, money is being spent on litigation. That's what's happening at the moment, because there is no insurance. If you're in the public sector, private sector, the doctors do have their insurances and the hospitals, but not in the public sector. Business and management is part of this classification. Human resource services, that's employee risks, general security and safety, people and assets, and then societal risks. And we have to monitor all of this as health practitioners, because it affects us. Just think of what's happening in society, the risks that we have. If I take you back to COVID, when everybody was, you know, when they closed off all the bottle stores and no alcohol could be sold or transported in cars, you know, the hospitals had the trauma cases related to alcohol abuse was less. In fact, there was hardly, it was minimal. And we could use all the time and the resources we have for our patients that came in with COVID. As soon as those bottle stores opened, society was just those out there that love having parties on a Friday, Saturday, and then have fights after that. You know, then the hospitals look like these, you know, it's like a war zone. Very sad, you know, how these risks in society affects us. But it's there, and we must take note of this gender-based violence. Right? Today, they had a long discussion about what they're doing in Cape Town about gender-based violence at one of the places in, I think it's Mitchell's Plain. And even the Minister of Justice, he was also there, you know, sharing in what they are doing. But it's also trying to address risks. Healthcare-related risks, we've now discussed quite a few about that, include risks to patients and staff, infectious diseases, hazardous material, radioactivity, adverse clinical events. And I want to refer you to organizations like the National Department of Health can assist you with, if you're putting things together, Office of Health Standards Compliance, and COSASA. They specialize in risk management, identifying risks and putting plans in place. So one must seek the specialists if you need to, in any way, if you need support with your risk management. Now, who are the role players, that's responsible for problems in your hospitals? The board of directors. I just mentioned COSATA, where I'm a board director. But you have boards of directors and fingers are pointed at them. The managers, the risk management officers, the professional healthcare practitioners, the government officials, occupational health and safety officers, occupational healthcare practitioners. These are role players in the health environment that's responsible for identifying risks. But I like to say it's all of us, not only linked to specific people, it's linked to every worker that's that works for that health establishment, even if it's the sweeper, the cleaner, anybody, the one working in the gardens, taking care of the gardens, and identifying that now there's a risk of, he could easily come and tell you that on the other side of the fence, there's a lot of rubbish. And that is potentially going to we'll have rats infestation, and that's going to come over to the hospital or to the clinic. So everybody's vigilant. Everybody's on the lookout for any kind of risk that will affect patient care in the hospital, not only specifics. And then the underlying dynamics, the institutional determinants. There are very specific aspects about the institution, the business ethics that we have to function within, and ethical leadership is critical. And as I mentioned that depending on your leader, if your leader is ethical, and that's one of the things somebody said not so long ago, a professor from UNISA on Africa Day. He was interviewed early morning and he said, Africa has got everything. We've got gold, we've got diamonds, we've got oil, we've got everything in Africa. What we lack in Africa is ethical leadership. Now that should be one of our key aspects that we must function on, that we must work on, that we basically develop from the young practitioners that's in the clinical environment to grow basically to grow in the profession, that we develop that ethical leadership. All of them should be grown into that they are committed to what they are doing for patient care and they're done in an ethical and legal way. And then there's, of course, the stakeholders, the community engagements, which is also critically important that we, how does that impact on your institution? So health management is all about prevention. We have to identify risks and we have to be vigilant. We have to really be smart about our practices and not be narrow-minded. And I just thought I'll add this: life is about managing risk, not taking any. I remember going back to my school days, the maths teacher said that when we get into our cars, then we are 80% near to our deaths already, because the accident rate is so high that that you easily can also make an accident or somebody can bump you. And isn't that true? You get into your car, it doesn't guarantee you that you're going to get to the other side in a whole piece, or get back home again. And I can't help not sharing with you risk modeling. James Reason, very popular. He says that in an environment, there are latent failures, organizational influences, unsafe supervision, preconditions for unsafe acts. Unsafe acts, it's happening all the time in your clinic, in that clinical environment, in the health establishment. And many of us just ignore it, that's the latent failures. But the day comes where you have a problem and there's an active failure and it costs millions of rands. Instead of making sure that you address the problems that you identify. Safe quality patient care is a comprehensive approach. And these are the 6 aspects that all have risks, your organization and administration. What the gentleman is doing right there with managing the finances, or it could be a share also, like working with the finances or whatever they're doing, the HR department, but the organization and administration, there are risks there. And those risks must be identified. The flaws must be identified, or potential risks must be identified. The same with behavior. All of us are different. We all have all kinds of behavioral kind of, how the way we behave, we kind of, how can I say that? The way we do things, traits, behavioral traits, some of us, and we all differ. Some of us are very committed. Some of us have don't care attitudes. Some of us just think, it's just another patient. Some of us will just think, and I was looking at last night, I was in consultation, and the pulse rate was 134, 134, 134, 134. Now, is it possible that the baby's pulse rate remains 134, 134, 134? Somebody took a shortcut, somebody. Because that definitely, and especially a baby's kicking, and a baby that's in utero also, baby kicks. And the same with us as individuals, whether you're an adult, your pulse is changing all the time. But this child's pulse was 134 all the way. Then leadership and management, there are risks there as well. So we must make sure that our leadership and management is really up to standard, that we don't have problems there. Because if our leaders are not well developed and that they don't do what's right and proper, and with the specific managerial skills, we are in trouble. Procurement also, I'm not going to remind you about what happened during the year and what was said about the procurement, about what happened with COVID and the problems, is that it was in health that we identified. And the people that were involved were health, they were doctors. Now that was actually something that hit me very hard. I thought, wow, this is doctors, the MEC of Gauteng, the national minister, and then there was something in other provinces as well, just to mention a few, but these are doctors. And one wonders now, shouldn't we get, if you become involved in managerial activities, shouldn't you build your capacity in leadership and in management skills before you, because it is a fact that one would just say, yes, I trust you, I'll sign. Oh, no, that's fine, I'll sign. And then you're held responsible for that. Then the clinical problems that we have. Yeah, my research showed that over 90% of the patients that had adverse events were because of clinical problems. So that also is something that needs to be, if we need to provide safe quality patient care, we need to do what's right and proper, follow the guidelines, act according to the whatever the patient is now showing clinical, whether it's any clinical manifestations, we need to respond to that. I stood at the bedside of somebody and the pulse rate was something like 130 odd, and it's an old elderly lady, but the nurse didn't think that that was a problem. It was an RN, and she really didn't think it was a problem. I said, ain't you going to do something about this? This woman is running a race. So we need to also be on par with what we are doing in the bedside, and our environment should be conducive for safe, quality patient care. So these are my pictures that I showed you, and I think Dr. Lesego knows my pictures, but these are the questions that, when we do things in the clinical environment, how it basically impacts on us. And here are so many risks because they took a shortcut, these health professionals, sisters, midwives, but they were RNs. And the risks that's linked to just putting 2 babies into one incubator is very high. There's a cross-infection risk. There's a quality management risk. The identification of these babies, giving them the incorrect treatment, right? That's all problems. And it's not family, they're not twins. This is just to show you, this is taken by the Office of Health Standards. And when we just push beds close to each other because we're trying to make space, we're actually creating more problems for ourselves. Patients lying on the floor, sedated patients on the floor and left unattended. How many risks is linked to that? How many risks is linked to the patients that are basically with beds that are close to each other? The respect and dignity is compromised, including the risk to cross-infection, the risk to injury. And these risks lead to litigation. Patients may go out of there and say, I was lying there in that hospital. All those patients were on top of me. Others were all near to me, and they heard what was wrong with me. The doctor spoke so loud about the cancer I have that everybody now knows about the cancer I have. And then their families come and visit. They also get to know. They can sue us. That is what happens if you don't identify these risks and make sure that it doesn't happen. With patients lying on the floor, easily somebody can tramp on the patients. They're sedated. They can wake up there and say, my arm is sore. I've been tramped on. They can take us on. And this very famous picture, where the nurses thought they'll just make some lithotomy poles. Just look at what the poles look like. Right? They compromise basically the risks for cross-infection, injury, and human dignity violated. Look how filthy are these poles. But they were used for patients, and they were used a number of times for a number of patients. And my last picture to show you is that we're always aware of expired products that we are using, whether it's now the blood, these tubes that we are using, or anything that we are using. Are we aware of that? The medications we are using, are we looking at the expiry dates? Even if it's at home, it's a practice to look at, I bought this some time ago, is it still okay? Now, so more, it also has to happen in the hospital. So adverse events is an incident which results in harm to a patient. Harm implies impairment of structure or function of the body and or any deleterious effect arising therefrom. Harm includes disease, injury, suffering, disability, and death, and may thus be physical, social, or psychological. And this happens, adverse events come because of risks that were not identified and were not addressed in time. And patients are injured in hospital, they fall, they hurt themselves, they are infected. Think of your infection control that's not like it should be. There's a number of things that leads to adverse events. Adverse events may also be classified between extremely severe to minor or insignificant. And my research showed that most patients in the state, most of those patients that ended up with the lawyers, they had extreme problems. It wasn't minor cases. The minor kind of cases and mild cases were in the private sector, because those people have money, they can go to the lawyers with any small thing. In the state, what happens if it's small, patients just look past it and think it's maybe the act of God, that is what happened. But If it's severe, like a cerebral palsy or something like that, then they go to lawyers. And that is why basically the research showed that most cases were extremely severe. And what James Reason says, because of his cheese model, he says, you know, he compares it to cheese with the holes in the organization. And if these holes, you have barriers to most of the things that are happening in the health organization. But if those barriers break, they are so sensitive and they line up, as you see, a non-protective ventilation strategy. There's inadequate supervision, non-application of guidelines, communication is poor. Your junior staff is inadequate training, low or high caseload. If they align, it leads to adverse events. It's almost like a clash that occurs. As a young practitioner once, you know, I was only not even a year in nursing, when I said to two nurses, these were male nurses, and they were around about 20 years already. And this youngster said to them, you know, this patient, you know, we need the wound care should be aseptic. And because this patient had burns, severe burns. And they said to me, and of course I spoke about the cap, wearing caps at that stage and all about the whole bit about how the patient had to be managed. And they just said to me, oh, sister, you know, just show me one patient. I've been around now 20 years already and I didn't have a problem. And you know what happened? That particular patient died because of septicemia. Now, you see that kind of behavioral element that basically sets in when people have that attitude about they've been around long and they leave things to happen. They leave the junior staff. And I want to specifically speak about those ComServe nurses, the ComServe nurses that are not supervised, you know, that basically are left to do the work as if they are registered nurses. If something goes wrong in that clinical environment, is that, and they were in charge, the leaders are responsible, not those nurses. And somebody shared something like that with me once, where these junior ComServe nurses were left to look after patients, and then they started looking for a particular patient. And this was about 4 o'clock when the family came looking for them. You know, where's their mother? And they said, oh, yeah, she was here. And they started looking for the mother. You know, they found the mother behind the clinic, dead. Now, who's going to face the music? That was now the responsibility of the leaders of that institution to give answer to that problem. That is what happened. So risks must be identified and managed. So identify and prevention of risks is critical. And I'd like to say that you ask the question, how are we doing? And can we do it better? This is a question that you can always ask in whatever you are doing. Where did we go wrong? What should we do to fix it? The goal is to provide safe, quality patient care. Don't be satisfied with the way you did it yesterday or last week. Ask yourself the question, isn't there a way to do it better? And that is why we always need to keep ourselves on par with what's going on in the literature, to read and about how we are managing our patients. What we've learned, you know, yesterday they were discussing something about, and they interviewed one of the professors from Stellenbosch University and the head of the rector of Free State. And they spoke about, you know, what when we finish with our careers, we've now qualified, we have a 4-year degree, and now we know it all. I say it only takes 4 years for you to be really already out of date. Only takes 4 years. You have to keep yourself up to date all the time because there's new things that are being taught all the time, new things being invented all the time. So it only takes 4 years. It was a very interesting discussion about when one thinks, you know, when you finish with your studies, then you think you've got a degree and now you know it all. I remember as a youngster, when I got my degree and I was placed in an ICU and they said to me, well, now this is now you need to know your ECGs. And I said to myself, but you know, the professor never taught us this ECGs. And now suddenly, but I had to go and learn those ECGs and I felt like I knew nothing. So keep yourself up to date. Evidence-based practice is critical for all of us. South Africa has also taken, a lead in whatever and we're proud of our professionals, our leaders, the scientists, especially with COVID. They've shown quite that we really don't lag behind the rest of the world. But in the quality improvement in healthcare, the strategies that we have, we have our constitution, we have the National Health Act, we have the National Health Amendment Act, which is soon to be an act that's going to change. We have the Regulation 67 norms and standards that was introduced. The National Health Insurance soon to come. And there's National Core Standards that was introduced in 2008, which many of us still practice. If you practice those 7 domains, I can tell you, you will meet all the standards that's linked to Regulation 67. And then there's 6 national priority areas: waiting period, availability of medicine and supplies, cleanliness, improve patient safety and security, positive and caring attitudes, infection prevention and control. These 6 national priority areas made a difference. If we go and look at the stats, it made a difference. The only problems that we have is managerial, operational management. That's the leadership, and those 2 areas is still our problem, but it definitely made a difference. All of us became aware of waiting periods, the availability of medicines and supplies, and so on. But there's still a lot to do on those activities, those priority areas. Then, of course, we have a patient charter. We have the Batupeli principles. We just need to practice it and see that it's implemented all the time. So those the promulgated regulated norms and standards, the 5 domains, you're all familiar with it. And I can tell you, this is going to expand. It's not going to just be the user rights, clinical governance and clinical care, clinical support services, governance and human resources, facilities and infrastructure. All of those activities are going to expand because a developmental approach has been taken by the Office of Health Standards. Because if we had to jump to the way the 7 domains are, which is over 100 aspects, we would, in fact, there will be not a single health institution in this country will be found compliant. So a developmental approach was taken. And just to touch on quality standards, because we've now spoken about standards, is that standard may be defined as a description of a desired level of performance for judging the quality of healthcare. Structure standards, your process standards, and outcome standards. This is important. How do we develop a standard? We sit together, a few experts get together and we critique our work, we work through it, we send it to others to look at it so that we eventually, experts have looked at your standards that you have developed. Now it could be structure, it could be process, it could be outcome. But if we can work on these 3 aspects, then we won't have problems. But unfortunately, at the moment, we do. So your structure standards includes infrastructure, your buildings, the wards, the theaters, HR, guidelines, SOPs, policies, equipment, information, and then technology. We may have all of this, and you may have heard also that we are good at designing policies, but we're not good at the next step of implementing those policies. So if you've planned, you've identified your risks, you've planned, it's part of your structure. You're going to implement it, and then you're also going to measure it, basically. That's critically important. The process must be, and then take remedial action. And there's measurable indicators that must be introduced: your infection rates, your adverse events, hospital-acquired infectious sores, patient satisfaction. There's various ways of measuring whether you are meeting safe quality patient care. Are you doing what's right and proper? Are you listening to the patients, what they are saying? Or are you just probably putting it down as another patient that is moaning and just ignoring the patient? Because this is some of our attitudes. I didn't tell you that attitude is actually the 21st century problem. So to summarize our talk for today is that we spoke about risk management. And the context of that was the Constitution, corporate governance, legislation. The purpose to safeguard the patient, employees, and the public during healthcare provision. Safeguard the health organization against potential risks, sustained service delivery. And then the process was that we identify, we assess, we apply strategy analysis, strategy development, strategy execution, strategy review. And then the dimensions that we refer to also is the corporate governance, business continuity, occupational health and safety, environmental management, and adverse event management, incident reporting. Who are the role players? The board of directors, the healthcare organization, or if we have to think of the state, let me go back to that first one. If there's any case that appears in court, it will be directed at the MSc of that particular province. Okay, they don't ever speak about a doctor or a nurse. They will always refer to the MSc of the Western Cape or the MSc of Limpopo that has been in the news. Yeah, and I'm sure some of you must have said, yes, is right, what she's been doing, and some may not have gone down that because it was unethical to have spoken there. So I leave that to you in deciding, was that behavior, was she ethical in what she did? Then professional healthcare practitioners, there's the government officials, the risk management officers, occupational health and safety officers, your occupational health practitioners, stakeholders, community representatives, and volunteers. But to add, all of us working in a health establishment must identify risks and is a role player. And then you have your underlying dynamics, the institutional determinants, the business ethics, and stakeholder community engagement. So these are my references. These are textbooks, Boyens that I've used, and I also use Miller, and then also the acts that are referred to, the Constitution, the Health Act, National Health Amendment Act, Patient Health Disaster Management Act. And one, if you take the discussion further, it's actually that you have a lecture on disaster management, infection control, because it's all related to risk management. I thank you.
Yes, Prof. Wow. Hey, what a very empowering session. I mean, I'm just empowered myself, and we really appreciate this particular session. I think I see the audience is mixed. You know, there's nurses, yes, but there's a lot of doctors here. There's a lot of pharmacists. There's a lot of other allied healthcare professionals. So even if we call this nursing practice, we are really encouraging an interdisciplinary approach, because we have to find ways to work together and collaborate. So yeah, thank you, Prof. So maybe before I ask questions from the Q&A, and maybe allow a few hands as well from colleagues. So if I'm transformed today, Prof, by your talk, where do I start tomorrow? What do I do? And maybe approach it from me as a health professional, not necessarily as a CEO, because maybe CEOs might have a little bit more control. But as a lay health worker, clinical associate, nurse, what do I do tomorrow? Where do I start? Thanks, Prof.
Well, if I was in your shoes, I will assess my environment where I am functioning in,
Yeah.
and my practice and what's expected of me. That's why I mentioned in the beginning is that we can actually box ourselves and put ourselves in this box and say that, look here, these are the things that governs me. I have these legal aspects, I've got the ethical aspects, then these are the laws that's around me. So if I can answer questions related to that, then I'm doing well already for a start to assess that. And what are the risks that's related to this? I need to know what I'm doing. I need my knowledge should be up to date. That's why evidence-based practice and knowledge, keeping yourself empowered. And it was a very interesting discussion last night when these two professors said that it just takes you 4 years. You come out of the university, you got your degree, 4 years later, you're outdated. You know, so there's just a lot of work to be done all the time to keep ourselves up to date. And those are questions you'll ask as an individual too. Am I keeping myself up to date? Am I still okay with what the way I'm doing, the way I practice? Is this still the best way? You know, isn't there a better way?
Great, great, Prof. And now with the support, so if I do identify risks in my ward, in my unit, my private GP practice, you know, how do I then go and gather support for me to resolve some of these? Because I think there's certain soft skills that I think we lack a bit as health professionals, whether it's advocacy, you know, communication. But how do I go about garnering support so that I have a team, at least, of people I can work with to try and resolve some of these issues?
Well, I will start with my peers, you know, with my peers, that we start sharing the problems that you identify, and also to ask them if they are experiencing the same as what you are experiencing, because one sometimes think you're alone, but then the problem is actually quite common amongst everybody. They're all telling you that they also have the same problems, and then start strategizing from that you will start meeting the leaders and to share with the leaders the problem, and to show, of course, with some literature, some reference to the literature, you know, that if we don't address this problem, you know, USA has found this, or it happened in France, it happened there, it happened, you know, this is what happened in Africa. Come with some references, because this is how we do research also, you know, that we identify these problems and then we start reading about it to find if there are others experiencing the same problem.
Same.
So that would be, but I would really say that one also as a team, you know, group address, one or two go to the CEO or the leader of that ward and discuss the problems that you have identified in that particular ward to start, if it's on that level, start. If you're a cleaner working out there, even those cleaners, I mean, the cleaners identify interesting things, and they bring it to the attention of the leaders also. You know, they go and they speak to this. That I've had that experience already, where the cleaners would identify stuff and bring it to our attention. So, and all of us in the health establishment, you know, we all dots on that circle.
Yes.
We're all dots, and we all contribute to safe quality patient care. Yeah.
Superb, superb, Prof. And before I go through my last question, which is very important, you've mentioned when you were young and how you wanted to do the right thing, but the most experienced people sort of didn't buy into, you know, and there's a concept of a culture of low expectations, you know, where people have sort of accepted poor quality as the standard, and we see a lot of workarounds. You showed the maternity polls, you know, which is a workaround for a certain problem, maybe, which might have been picked. But that workaround, the low quality standard, is now the norm, or it's accepted.
Yes.
How do we transform the culture of and start to have a culture of high expectations and really to really provide high quality care all the time.
Yeah, what did I do at that stage as a youngster? I was really very young, just had my degree, and I wasn't there. I was a few months. I stayed on at the academic hospital, and then I went home. I only stayed there for 4 months. They said to me, "Hi, sister, when in Rome, you become also a Roman." So I said, before I become a Roman, I have to get out of here because I was not going to beat those guys. They were big guys anyway, also, and they were around for about 20 years. And I even remember their names also still. But I left that institution and not sorry that I did, because I could never function that way, and so that's a situation where you can't beat. But basically, if you want to move on and make the change, is that you'll have to win a few people to work with you, because it's difficult if you're on your own. A few must be good, and then start basically with giving talks, giving lectures. And I know it's difficult because some people will say, and not listen and so on. But that is the way to go, is that you just continue showing your commitment. People used to ask me when I was working in ICU, are you doing the ICU course? No, I'm not doing the ICU course, but I need to know what's going on with the patient. So I'm reading up. Why is it that this must be done? Why are they doing this? And I wasn't even doing ICU yet. I was still a youngster. And that was before I went home. So, but that is, it affects others, and especially the leadership. If the leaders have that in them, it basically rubs off on the others, that they also start becoming like that. I have that kind of feedback I have from many of my students that would say that they always look up to me for that, and this is what they learn from me. And, so, but one must be consistent in what you're doing, that you're not always one day like this and one day like that, that you always do the right thing. You are always an ethical leader.
Consistent.
Yeah.
Superb.
Consistent.
Superb, Prof. I want to put someone on spot. I might be allowing, I see Mr. Letlalo. I hope it's the Mr. Letlalo I'm thinking about, who's working in a district as one of the senior managers. I just want him to just make a comment on his view of the talk and some of the issues raised. Mr. Letlalo, my apologies for putting you on spot. I don't know if you are able to unmute. I'm just trying my luck. Mr. Letlalo. You may unmute if you do hear me. Yeah, otherwise I think we will continue. Now, Prof, if you go to the chart at around 1858, let me see if I'm able to go there, and I'll read it to you because I thought that was a two critical comments. 1858. Yes, from Loiso. Loiso, please raise your hand if you would like to ask your question live. He says, I'm a new unit manager. I'm still a novice in this position, and what I have seen is scary. As a result, I'm not sure what to do besides sport teaching, as the unit is fully operational. I'm thinking of quitting, Prof. We put people without preparation, and even when they are there, half the time there isn't a lot of capacity building and support. In healthcare, you become a manager just because you have treated patients for 10 years. It means you can run a hospital, not that you have the management or leadership capacity. How would you advise Lois or Prof? I'm not sure if it's a female or male, but he or she wants to quit because it's too much as a new unit manager. Yeah.
Yeah, he mustn't quit, or she mustn't quit.
Yeah.
She must build capacity in her managerial skills and leadership skills, and identify a mentor, somebody that can be there to guide them, that you can always discuss. I'm reminded of somebody that cried. She was a student still, and she cried. And I knew her when she was a little girl. So now she came to do nursing, and she just wanted to give up. So I said, that is how it is. One day the sun is shining, the next day it's very dark. That's how nursing is. And she became a full professor, but just identifying somebody that she could talk to with problems, or there's something, how can I do this? So a mentor, and this is what we may have to do, Lesego, is that we may have to start something of a few mentors to make people, that we have a few practitioners that make themselves available as mentors for young nurses, young people. Because that's the risk. Remember, I showed you that slide there of James, is that you basically, if you have somebody that has poor supervision, or they don't have the necessary support, like junior, those leads to, that's a risk already. So we're going to end up having adverse events. Things may go wrong, like it happened to those two nurses in this comprehensive health environment, where they looked for the patient when the mother came, the family came to look for the mother, and the mother was dead, lying behind the clinic, but they were just basically ComServe nurses, and the law is very strict on that, is that they should not be left unsupervised. So during the year when they ComServe, they must make the most out of it to get as much out of the people that's guiding them. And then identify somebody that can give them guidance, somebody that they can turn to always, that they can pick up the phone and ask for guidance. So that is something you could think of, or in your mentorship. You have a unit of mentors.
And to be honest, Prof, I've had a lot of requests around that particular space, and we need to discuss it. But let me see, Mr. Letlalo, I see you are unmuted. Are you able to hear me?
Yes, I am. Can you hear me?
Yes, we can hear you a little bit soft, but yes, it would be nice just to get your commentary, Mr. Letlalo. Apologies for putting you on spot.
No, thank you very much, Dr. Mawela, and thank you, Prof, for the presentation. Just last week, one of the CEOs in Mpumalanga was asking me about the risk register. And while we were still talking, the Department of Labor visited my hospital. I gave them the risk register, but it was a district-wide risk register. And when we were walking around, they started to say, but this one is not necessarily addressing your hospital from the gate. What we did is, I've realized that for risk assessment, you need to walk from the gate until the mortuary. That's how you are able to do a perfect risk assessment. And when we were walking through, then I realized that no, for all these years, we've just been doing it for compliance, not necessarily to address the risk which we are now facing. At that time, we did not have water. When I look at the risk register, it did not talk anything about what in case we don't have water. What should we do? Because we are provided by the mine. The mine is the only one which is giving the water. The municipality is not giving us water. We are not connected to the municipality. What, in terms of that, what do we do? So I realized that I was reading through, during the day, I was reading about the risk management, because I want to present to my exco and my managers. Then when I saw this, I said, my goodness, it's like it just fell at the right time. When you were presenting, I was looking and saying, look at these pictures, look at this. This is exactly what I saw. So I need my risk assessment team to go through this. Then we'll be able to say, this is the risk register for my hospital. And I'm going back to tell that CEO that, no, forget about what I've sent to you. Do it this way, because I'm from this webinar and this is what I've learned. Thank you very much for that.
Yeah, and it's not a dead book, eh? It's not a dead register. It's alive. because the
Right,
things are
that's what I was
changing
gonna
and
say.
there's more risks identified and some risks are resolved. There's no more risk. Let's say it was a staff problem and you now have all your staff and it's not a risk anymore. You have everything in place like it should be. Well, that's a dream. I think it's a dream in South Africa, but then then it's resolved. But
Yeah.
there's risk, and normally when I talk about risk management, I normally say to the students that from the time you drive in by the gates, you are already, your eyes are going around and you are identifying risks. And if there's something that's potentially a threat to healthcare, patient care that day, you go and you pick up the phone. Let's say it's the grass is very long in the, on the premises, very long, and it's a problem for rats, infestations, things like that. You go and you pick up the phone and take an autocratic decision to phone whoever's got to cut the grass and tell him to do it. Don't have a meeting first to decide who will cut the grass.
Hey.
Go and do it. That's autocratic. So that then your grass will be cut, and tell them, So, and even as the students, when I say to students, that now you've come into the hospital, you've identified, now you walk into your ward. From the time you walk into your ward, every room you pass, you are actually looking around and looking at, are the patients safe? Are there problems? So, and that's what we need to develop, that culture in the environment, that they are aware of potential risks in the environment that could harm patients.
Hey, thanks, Prof. Catherine at 1859 is talking about something which is very topical in a way, but I think she works at one of the hospitals, and she says the issue of patients laying on the floor, it now becomes a political issue. As nurses, we find ourselves in situations like the one you put in the picture there. And he says leaders in government did not plan for population explosion. However, we as nurses, we have to bear the brunt. Prof, what can she do? What do we do, Prof? Yeah.
Yeah, you see those young nurses, they were saying they're not going to be the accomplices of patients dying. You saw that. That was just before I went on holiday. There was the young nurses that's taking action. And I said, good for you, because I was also very young once upon a time, 1994, I was pretty young. And there was, it happened in 94, where the trade unions, they took over in the hospitals. And there was really very little in place. The policies were in place, but they would just, they would, the bins get thrown over, the dirt is thrown over, the food trolleys are stopped and all that. And I was the youngest nurse manager at that stage. And I got up in a policy making meeting and I said to the head, I would like to see the Minister of Health. And they looked at me, all those big people sitting around. Remember, I was very young. So they now all looked at me. How can I say I want to see the minister? So I said, if the trade unions can see the minister, then I can also see the minister on behalf of the patients, which I did. They were forced to arrange a meeting for me with the minister. And then I had the support of all those people sitting around the table. They all went along and we made a change. So we must have that courage to be able to speak to the leaders about patient care. As an Office of Health Standards Compliance Board member once, I also spoke in Parliament, when we have to go and meet those committees, the health committees, we have to meet them. So this portfolio committee, and there we just raised the issue of training. I said, it's unacceptable what's going on now, because if I'm not sure if you're aware of it, but for the past 2 years, 3 years, we were not producing any nurses with any postgraduate qualification. Because the legacy qualifications came to a halt in 2019 and the council had nothing was in place yet, so it's slowly coming in place now that they are training. But that caused quite a gap in the care for patients. But I took the opportunity to open my mouth in Parliament when we were there at the Health Portfolio Committee. So it's this kind of things that we have to do. We have to talk. When patients are lying on the floor, we must prevent it. We must go and stand in that director's office, the CEO office, even like throw you out. You say, then I'm going to the next level. But I will not allow. And you know what will happen? We'll have the population on our side as healthcare workers. If we start taking a stand against the way the politicians are managing situations these days, they will. I mean, now suddenly they became aware of the many people that just walk across the border and come and get operations in our country, which we pay the taxes, and nobody said anything. I was in England now, and you know, when I opened my medication, I was short of they basically had on the chart, it was supposed to have been, it's written 1,000. This is now for the pharmacists, but the actual medication inside was 500. I only had half the treatment. And here I'm sitting in England. Now I must try and get the other half because I'm going to be short of medication. So I go to one of the pharmacies out there and I explain my situation. No, he says you need a prescription. We can't. So I said, I do have a prescription, but it's a South African prescription. Oh no, you must have a UK prescription. So, okay, now I contact the people in South Africa. And I then also went, then I went to a second pharmacist and he said to me, man, go online and do it online. But do you think they would give me that medication? They couldn't care less. But we provide surgery to patients that walk over the border and we don't ask the questions. And suddenly now the politicians are now awake. They knew it all along. They knew it all along. But we need to identify this and we need to bring these things to their attention. We need to hammer it as healthcare providers. You'll see the public is really going to love what we do if we stand up for them.
Yes. Thank you, Prof. I wished we had exactly 2 hours with you. This is quite empowering, Prof. Maybe one question and then maybe we will then sum up because it's already after. Someone is asking, where do I get this risk assessment tool to assess my clinic, my facility? I would think the national cost standards tools are sort of in a way helping. I'm not sure if there's a specific tool that people can use.
Yeah, the Office of Health Standards can assist. Yeah, there's quite a bit of stuff that you can even get on the internet, but it's the layout that you can have. You have your identify the risks. I'll send you a little example of the headings that you can have and the things. I'll send it to you and you can.
And we can share with everyone.
Yeah. Okay. Yeah. So it's the risk register. Yeah.
Yes, Prof. So Joshua,
I had to do the register for the Office of Health Standards for SAMLA as well.
Oh yes.
Yeah.
Joshua, as we close, says, Prof, you just reminded me of this quotation by Florence Nightingale, and it was shared by this clinical care platform on Facebook. And he's quoting her. She says, let us never consider ourselves finished nurses. We must be learning all of our lives. So all for the rest of our lives, we must commit to continuous professional development. And I think that is also what I got, Prof, you know, as you were teaching, that as a health worker, you can't be competent for life. You can't know it all for life. After 4 years, we risk being, you know, basically very out of date. So platforms like this one are very crucial in maintaining competence and sharing evidence-based medicine. Prof, share with us your closing remarks and encourage our health workers because they are facing a lot of challenges. And I remember WHO a few years ago, they sort of were trying to figure out what is this ideal clinician. And some of the things they mentioned, they said, yes, you must be a good clinically, you must know your work. But the other 4 dimensions, I think it was a hand, there was advocacy, there was communication, You know, there was something about ethics. I see that as health workers, we tend to spend most of our time refining the clinical piece, but we are not really good with the other things as well. And like when I asked you how we respond to some of these, you've mentioned the importance of a health professional as an advocate, as someone who's assertive, who's able to communicate. You know, we must be very confident, you know. But yeah, Prof, your closing remarks on today's session.
We must remain positive and have hope for our country, you know, and I've said it to my family that left the country. I said, who taught you to read and write? You know, so it's our country. We teach them and we teach them to read and write, and then they leave the country. But we must have hope for our own country, be committed in what we do, have compassion and that caring attitude for our patients, never to let our guard down. Our patients come first. And this thing about, you know, somebody must prove me wrong to say that attitude is not a 21st century problem. We must get rid of it. It shouldn't dominate, you know, in our practice. It's something that's really sad that has come in, and we should not be influenced. We must really just keep going and be positive in what we are doing. We're doing it for our patients. And Lesego, you also, you know, you're getting old also in this job. Yeah, be committed and form that unit of mentors. So
yes,
that one can, that, you know, that we can guide the young generations that are coming. It is tough, you know, when you come in. I was told as a young, and I'm talking a little bit too much, but as a young registered nurse starting in cardiology, now imagine starting cardiology and you really didn't learn anything about ECGs. But here you are told, and those days they didn't orientate you. You know, there was no induction or anything like that. You just started and I remember this registered nurse telling me that if you see these, this is now the exorcist studies, you count them, these ventricular, and if they're 5, then you start treating the patient. And if you see the treatment down and it goes, you know, fibrillates, then you must now shock the patient. And make sure that you stand away from the bed, otherwise you'll shock yourself, you know, defib the patient, but you'll shock. That was my orientation, you know, and I was so scared. I went that night and studied ECGs. I never got half of it into my head, but I did remember the ventricular systoles. And the very next day, I had a patient that I had to defib. I defibbed it that day, the Friday night and the Saturday morning. And then the doctor says, and I even remember his name, this new sister is very good at what she is doing, but she must now allow the patient to die. Now, wasn't that sad? For an 84-year-old to have been there, should never have been in ICU. I only had it on my head that I'm not going to be blamed for anybody's death. You know, I must make sure that this patient is pulled through. That's all that was in my head. But from a managerial point of view, it was wrong for that patient to have been in that unit at that time.
In the first place,
to have died with dignity was actually what should have happened.
That's better.
So we mustn't allow that to happen to our young generations, our young people. We must have a unit where they can consult. You know, we could make ourselves available, even if we put ourselves on a roster, who's on duty, that people can run. I sent a message to my students today. I said, I'm missing you. We are dying for you to ask us questions, you know, and they're halfway through the scores that we are offering. How's things now with it? And immediately one of the students responded very happily that I had asked that question. So I think this is what we need to do. Be one up for the rest of the country.